Assalamu alaikum. Hi everybody. I would like before to start to thank the organizers for their invitation. Unfortunately today I cannot be with you in Cairo because Moroccan authorities closed all the frontiers. So I cannot travel outside Morocco. So thanks again for the invitation, especially for Dr. Abbas Zahir, Dr. Khalid Abdel Azm, and great thanks for all our friends and colleagues, our professors in Egypt, Professor Yahya, Professor Abadi, Professor Al-Kinani. Thank you very much for this invitation. Today I would like to talk about difficulties, failures and treatment option in limit and surgical cases. In our daily practice, we can have two extreme situations. The first extreme situation is when you have a mild skeletal discrepancy, and this is not a frequent situation. And the second extreme situation is when you have a big skeletal discrepancy. And between these two limit situations, we can have moderate to severe skeletal discrepancy with or without growth. And this is the majority of patients. These three options or these three situations are the majority of skeletal situation we can receive in our daily practice. And we need to have always a solution for different type of skeletal discrepancy. Today we will concentrate only on the big or the severe skeletal discrepancy, even if it is not the majority of patients we can receive in our daily practice. So what is the percentage of these cases? In general, we have between 3 and 5% in our daily practice. In my case, I do surgery for between 12 to 15 cases a year. So it depends on the type of patient you receive. In general, you can have 3 to 5 in each 100 patient that needs surgery. Before to choose a treatment option, we must have a classification. We have a lot of classification in these cases. I use my own classification, which is a therapeutic classification. I classify my cases in 6 groups. The first group is the patient that have a big syndrome with a severe skeletal discrepancy. These cases need to be treated in a special way. But believe me, these cases are the simple cases to treat in surgery. Why? Because they have a big discrepancy, you will not have a problem after surgery. Example, if we take the photo in the middle of this slide, this patient has an achondroplasia. And even if we correct the position of the jaws, the aesthetic result will not be very improved. But even if we don't improve a lot the the aesthetic result at the end, the patient, because they have a severe skeletal discrepancy, every changement will be really appreciated by the patient. The first patient on the left side is a Brody syndrome, and in the right side is a severe syndrome with a lot of problems in the upper and in the lower jaw. So this group, even if it can be considered as impressive cases, these cases are not difficult. It's clear that we need to have a special way to treat these patients. The second group are the common syndromes we can receive in our orthodontic clinics. Example, like palate cleft or labial cleft, or like the third patient on the right side, she has automandibular syndrome. And in these patients, we can treat them like an autosurgery classical case. Yes, they need not only orthodontic surgery, but we need to do also plastic surgery in these cases. This second group is still a simple cases, even if we need to do a lot of things in these patients. The third group are the normal cases with severe skeletal discrepancies. And in general, a severe skeletal discrepancy, we have 4 dimensions correct. The vertical dimension, the sagittal dimension, and in general, they have an asymmetry to correct. Yes, we need to do orthodontics and surgery to correct the asymmetry, because these patients ask us to improve the aesthetic, facial aesthetic. So the treatment needs to be done in a special way, with a special protocol. We'll see all the details later. This group is still a simple group if we follow a special protocol, as we can see together later. Moderate skeletal discrepancy are those patients who don't want in general surgery. They are surgical cases, but they don't want surgery. Why? Because they don't have a big aesthetic problem, facial aesthetic problem. So what is the option we can offer to this patient? We will see that we can leave this discrepancy if we cannot correct the occlusion with orthodontics. We can do camouflage, we can do surgery, but we have the third option, which is to leave the occlusion and to align the teeth, to do only an alignment of the teeth. The difficulty in these cases are bigger than the previous cases. Light skeletal discrepancy is the patient that can be compensated with an aesthetic facial problem. In this patient, if the patient don't want surgery, we can leave the face, and we can correct in these cases the occlusion, because the environment is favorable. And the last group is the most difficult surgical cases. Why? Because they don't have any aesthetic problem, but they need surgery. And these cases, if I ask you, please tell me if these cases are surgical in our point of view, I think that the majority of you will consider them as not surgical cases, but they are surgical cases because the discrepancy, skeletal discrepancy, is important, even if they don't have an impact on their facial aesthetic. So be aware with this patient, because they are the most difficult cases. What can we offer for these patients? These patients, we must correct, we must do a minimum correction with the surgery, because they will not accept a lot of modification for their faces. The surgery is indicated not for an aesthetic problem, but for a technical problem. For example, we cannot move the teeth outside the bone. And if we cannot do a lot of movement with orthodontics and we need surgery, so we can have two options. We cannot compensate, because if we compensate the case, we will have a perio problem. Or, so what we can offer to this patient is to align the teeth or to do surgery. But if we decide to do surgery, we must move the jaws in a minimum movement of the jaws. Look at this patient. This patient has no aesthetic problem, but when she smiles, she has a cant of her occlusal plane. Can we treat her with orthodontics? Yes, with mini screws, but it takes a long time, and we can have a lot of problem with ortho movements during the orthodontic treatment. This patient came to my office after 2 orthodontic treatments, and she asked me to do something for her smile. So I refused to treat her only with orthodontics, because she had already 2 previous orthodontic treatments. So I need to be efficient. And in this case, if we want to be efficient, we must do orthodontic with surgery. I treat her in 5 appointments, only 5 appointments, because the teeth were already aligned, so we only put the brackets, improving a little bit alignment of the teeth, and then after we send the patient to surgery. So the more we have an aesthetic problem, the more the case is simple. And the more we have discrepancy, the more the case is simple. So the most important thing to take in consideration is, if we don't have an aesthetic problem, the case is a difficult case, with or without severe skeletal discrepancy. So what option we can offer to the patient? I think the 2 important or 2 interesting solution is compensation or ortho surgery. We have a third option. Which is only to align the teeth for those patients who need surgery and don't want surgery. And for those patients, this option, I think we must avoid it. Because it's the teeth will not be stable when we decide only to align the teeth. Okay? So if it is possible to choose between compensation or ortho surgery, or to refuse the treatment if the patient don't want surgery. So what type of surgery we can ask the surgeon to do? We have three options. Surgery first. We cannot do this surgery for all our patients, because sometimes we have some teeth that limit the movement of the jaws. So we need to decompensate, especially when we have a vertical decompensation to do. Late surgery, this is the most important surgery we indicate in our patients. And early surgery, it's the surgery we can indicate when we need, for example, to do an expansion. What is the most important point to take in consideration to choose one option of the treatment or other option of the treatment? We have, I think, 8 elements to take in consideration. So let's start with the first important point. The first important point is the chief complaint of the patient. So, let's start with this first patient. This first patient came to my office with a clear demand. She wanted to improve her facial aesthetic. And the most important point to, or the most important in this case element to correct is the asymmetry. And this patient, the demand for this patient is clear. We need to do surgery and then orthodontic to prepare the teeth and then send the case to the surgeon. Well, when I saw the occlusion, the gap between the lower jaw, the lower teeth and the upper teeth is not too big. So we can correct this case only with compensation. Look at the skeletal discrepancy in sagittal dimension. It's not a big class 3, so we can compensate the case. So this is the final result, before and after. So we can do only orthodontic in this case. But because the demand of the patient is clear, because she wants to improve her facial aesthetic, so we were obliged to do surgery. And one important thing to ask the surgeon to do in class 3 is to move the upper jaw in the limits. They can move it, yes, the upper jaw more than the lower jaw. In general, the surgeon, when they receive a class 3, they move the lower jaw more than the upper jaw. And at the end of the treatment, we can have a good class 1. The face of the patient, even if he did the surgery, will still have this impression of class 3. So to avoid this problem, ask your surgeon to move more the upper jaw than the lower jaw when it is possible. It's clear that we have some cases with the big class 3 where we must move a lot the lower jaw. So this is the case before the treatment. We prepared the teeth. We didn't compensate the case because the patient wanted to improve her facial aesthetic. We decompensate the case before and after decompensation. This type of orthodontic treatment is really very simple orthodontic treatment. And we did, as I said, we did surgery. This is the final result. Our patient don't know what is class 1 or class 2 or class 3. They want a good aesthetic result. This is before and after. The correction was done with orthodontic and with surgery. We corrected the profile, the class 3. And the most important thing for the patient is to correct her asymmetry. And we answered the demand of the patient. Before orthodontic treatment, after orthodontic treatment, and after surgery. So, the second situation are the severe skeletal discrepancy with an asymmetrical face. In this patient, she has a cant, but she don't want surgery. She asked me to do the correction of her facial aesthetic only with orthodontics. Can we correct this case with only with orthodontics? Can we correct it only with orthodontics? We can correct it if the patient accepts a long orthodontic treatment. We can use mini screws and we can compensate the case. But this patient has previous 4-year orthodontic treatments, and she asked me to do only orthodontic. I refused to treat her only with orthodontic, and we decided at the end to treat her with orthodontic and surgery. This is an efficient protocol for these cases. So this is the case. This is the case before the second orthodontic treatment. We have an asymmetrical lower jaw, okay? What we did is to prepare the teeth. We align all the teeth. It's really a simple step to prepare the jaws or the teeth for orthodontic surgery, and then after, we send the patient to surgery, and we corrected the cant with surgery. 11 appointments. Only 11 appointments. This is the case before treatment. At the middle of the slide, you have the ortho preparation, and then after surgery. So the facial pattern is important because to choose one option or a second option, or compensation or ortho surgery. This patient is a beautiful patient. She has no aesthetic problem, but in my point of view, it's a surgical case. This is a difficult case to do with surgery. Can we compensate the case? Yes, we can compensate the case, but we have a problem. The gap is so important, we will have at the end of the treatment, we can have an perio problem. This is the final occlusion. Yes, we have a little perio problem on the lower incisor. We don't reach a perfect class 1, but I think this is a good result for the patient and for us. This result, is it a stable result? I don't think so. I don't think this is this result will be a very stable result. Why? Because we leave a small class 2. This is the final occlusion. Look at the perio problem after the treatment. The length of the crown is bigger, so we have a small recession because we moved forward a lot the lower incisor. This is the final result. It's clear we will not have an impact on her profile because we didn't do surgery. And it's, as I said, these cases try to avoid surgery. And the final result, I think, in general, when we correct class 2, when we do expansion in class 2 cases, the impact on the face is very important. When we compare before and after, we can have an impression that something important changed on her face. It's only by moving the teeth we can have this type of result. The third important point to take in consideration when we want to decide if we can compensate or to do surgery is the sagittal discrepancy. The sagittal discrepancy in general, if we have a class 3, it's more easy to treat, to compensate in comparison with the class 2. If we have a big class 3, in general, we must do surgery. If the patient don't want surgery, we must have a minimum of condition, of environment condition. Look at this case. This is a big class 3 with a big aesthetic impact. The patient and his mother don't want to do surgery for her son. So when I saw the malocclusion, I was really afraid to compensate it. But I have one important element that can help me to compensate the case, which is crowding. So I discussed with the mother that I will try to do my best to compensate the case, but if I fail, we will do surgery. And she accepted. She accepted. Look at the gap between and the skeletal discrepancy. It's a big skeletal discrepancy, but as I said, we have crowding, and the crowding will help us to do expansion in the 3-dimension. This is the final result. It's not really a very good occlusion, especially in the lateral sides. We don't have a good occlusion in the right and the left side, but in the anterior occlusion is acceptable. So the impact of this action is very important. We could compensate the case, and we could have an important impact on his facial aesthetic, especially on his profile. And even when he smiled, before the treatment, we couldn't see the upper incisors, and now we can see the upper teeth. And look at on the profile, we could correct the sagittal problem, and we have a better position of the upper lip. If we have a severe skeletal discrepancy in class 2, it will be more difficult to compensate than in class 3. More difficult, especially if we are in hyperdivergent cases. This patient we can consider it as a very difficult case because we don't have a big aesthetic problem. She asked me to improve the distance or the gap between the upper and the lower incisor. In general, when we have a class 2, the patient asks us to move backward the upper incisor. This perception of protrusion of the upper incisor is due to the lower jaw. Because the lower jaw is backward, the patient asks us to improve the position of the upper teeth. And the error we can do is to extract the teeth and to retrude the upper incisor. What we must do is to push the lower jaw forward. But this patient don't want surgery. And the class 2 is really very big. It's a full class 2. And if the jaw discrepancy and the burial environment of the patient will not allow us to do compensation. And the best treatment for this patient is surgery. And because she don't want surgery, we decided to treat her only by aligning the teeth and improving a little bit the occlusion between upper and the lower jaw using some special tools like mini screws in the upper jaw and trying to move backward all the upper teeth and forces on the lower jaw, but without the correction of the full class 2. We will correct only 15% of the class 2. Why? Because it is dangerous to move forward the lower incisor. So we use at the same time mini screws at the upper jaw and forceps between the upper and the lower jaw. This is the compensation we did. We didn't correct the full class 2. We still had class 2, but even if we didn't correct the full dental class 2, the impact on the psychological aspect of the patient is really very important. Look at before and after. The occlusion was improved. The occlusion was improved. You can notice that we still have class 2, but because we reduced the gap between upper and the lower incisor, really the patient was really satisfied. We will not have a big chance on the facial aesthetic because in this patient we really don't improve the frontal view or even the profile of the patient. But the patient, once she smiles, she has a good perception of the position of the upper teeth. So, the dimension to correct we saw the sagittal discrepancy. Now we will see the sagittal, the dimension to correct. The dimension to correct is really important to take in consideration. Why? If we have, in general, class 3 is easy to compensate. Class 2 is more difficult than class 3. And if we have a transverse discrepancy, a severe transverse discrepancy, we must know that if we compensate the case, it will relapse. And the patient must wear, if they want to stabilize the result, they must wear, in general, the fixed, a permanent retainer. Class 3, malocclusion, surgical case, but mild or light aesthetic problem. The patient wants only to improve the relation between the upper and the lower teeth. She noticed that she don't have a normal occlusion on the anterior teeth. The class 3 really is not very big, and when we control or we examine the occlusion, we can notice that the occlusion is really in a big class 3. We corrected the occlusion. We could reach a perfect class 1. We could reach a perfect class 1. And the correction of the face is the impact of the movement of the teeth on the aesthetic of the face really is very important. And these cases are the easiest cases we can compensate. Easiest cases we can compensate. Don't avoid this option for the patient. Every time we have a class 3, not a big class 3 like the previous case, every time we can compensate it with the elastic. We must know that it is these cases are the easiest cases we can compensate, and the impact of the orthodontic treatment on the facial aesthetic really is very, very important. So what we did is a simple treatment with elastics. In 5 months, look at it, in 5 months we could correct the occlusion in 5 months. This is the evolution of the treatment during the orthodontic treatment. Patient with transverse discrepancy. This patient is surgical patient, at least for expansion. She refused surgery. She has she's in class 3, she has a big aesthetic problem. So what we decided with the patient is to correct the transverse dimension with only orthodontic treatment, but she must wear the permanent retention if she wants to stabilize the result. This is the case before the treatment. This is the radio. We can notice that she is a hyperdivergent with class 3. We could reach this result, but we must know that this result is not a stable result, because if we can stabilize the compensation in sagittal dimension for class 2 or class 3, transverse dimension is in general a relapse in the majority of our cases. Before and after the treatment, and well, we could not, in this case, we cannot improve the aesthetic of the face because we didn't do surgery, but because we improve the transverse dimension, we can have an impact on the facial result. One of the most important also point to take in consideration is the periodontal environment. Every time patient refused to do surgery, we must evaluate the risk with the perio environment. These patients, like the previous cases with no aesthetic problem, if I ask you, please tell me, this is the case, is this case a surgical case? You will tell me no. But this case is a surgical case because the sagittal discrepancy between upper and lower jaw is very important. When I examined the case in my clinic, I was really surprised by the gap between upper and lower jaw. So, and the second problem she has is the perio problem. And I was afraid to compensate the case. And I told the patient that if she don't want surgery, and if she wants me to try to compensate the case, she must be aware that she can lose the lower incisor. Look at the gap between upper and lower jaw, and we tried to correct the asymmetry of the lower jaw by moving all the lower teeth forward. So with elastic, with forces, and we could not compensate 100% occlusion in the anterior. Look at the relation between upper and lower incisor. We still have a small gap. This is the final result. Before and after, we created the space of the lower first right molar. We could respect the perio environments. In this case, we have a chance, and the correction of the aesthetic face is not, the aesthetic face was not improved because the patient refused the surgery, and really the patient didn't have a big facial aesthetic problem. The sixth important point is the stability. We must also choose an option that give us for the orthodontist a minimum of security, and our security is the stability of the result. And I had a special experience with this patient. This patient came to my office, I think 12 years ago, and she asked me to treat her occlusion. She has an open bite, and she asked me to do an orthodontic treatment to close the open bite. When I saw this face, I refused to do orthodontic treatment. She came to my office 2 months after the first consultation, and she accepted surgery. So this is the occlusion at the beginning. She has a big class 2 with, not a big class 2, but a severe class 2 with open bite. Can we close the open bite with orthodontic? Yes, we can. Can we stabilize in hyperdivergent cases the correction of the open bite? I don't think so. So what happened during the treatment was when we started the treatment, the open bite started, the correction of the open bite started, and in the middle of the treatment, the patient asked me why I want to push her to do surgery. She told me, I'm satisfied with this result, but I know that this result will not be stable, never be stable. So the photo don't show all the details. If you want to evaluate the case, you must evaluate it with CAS or in clinic. And look at this occlusion. It seems to be a good occlusion. It seems to have a good relation between upper and the lower teeth, but it's not the reality. We still have a gap between upper and the lower incisor. So we decided, we corrected the occlusion, but this result, you have the occlusion after correction, 1 year after correction. The occlusion is stable. Why the occlusion is stable? Why? Because before and after, you have the occlusion before and after, stable 1 year after. But the occlusion is stable because we did surgery. We correct the discrepancy, moving the lower jaw with surgery. You have before and after. It's clear that the patient at the beginning don't want to improve her facial aesthetic, but this is an indication that gives us security, because in this situation after surgery, I know that the case can be stable even 1 year or 2 years or 10 years after the end of the treatment. The psychological profile of the patient is one of the most important elements or most important point to take in consideration. Look at this patient. This patient came to my office after a first orthosurgical treatment done in Paris. So when I saw the case, this is when he came to my office, he came with these brackets, with this occlusion. Really, I was afraid, because in this case I could not treat him only with orthodontics. Look at the case. This is the radii at the beginning. He did the first surgery, and the first surgery moved a lot backward the lower jaw. So we decided to do another orthosurgical treatment. So we decided to do orthosurgical treatment. So we prepared the teeth quickly. It's not very difficult. And I sent him to do the new or the second surgery. This is the case after surgery. This is the case after the correction. If I ask you, please give me your opinion, this case, you can consider it as a good case or not? Or at least the occlusion was corrected after surgery, after the second surgery, or not? The face is balanced or not? I think the majority of you will say yes, but the patient was not satisfied. The last point to take in consideration is patient motivation. Sometimes patients accepted surgery, and in the middle of the treatment they change their opinion. So we can stop the treatment when we decide with the patient to stop it without surgery, even if we don't reach all the objectives, or we can use special tools to improve the occlusion and the facial aesthetic. This patient came to my office after a first treatment. She has really a severe gummy smile, This is the occlusion after the first ortho treatment. Look at the torque of the upper incisor, really very bad torque. Look at the upper incisor. It's really the upper incisor is really very straight, and we decided to do surgery by correcting the torque of the upper incisor, and I wanted to send her to the surgeon to do an impaction of the upper jaw. She refused. When we decompensate the case, she refused surgery. So she accepted to have a compromised result. We put mini screws on the upper jaw, and we tried to do an intrusion of all the upper teeth. So we could intrude all the upper teeth. We have some small resorption on all the upper teeth, especially on the incisors. This is the occlusion after the correction after the intrusion of the upper teeth. She needs to do gingivectomy to improve the gummy smile. This is the occlusion at the end of the treatment. And the patient, even if she didn't do surgery, even if the impaction is not, or the intrusion didn't correct totally the gummy smile, she was really satisfied. But this type of treatment needs really a motivated treatment, because this type of treatment need a lot of time to reach a good result. So thank you very much. Thank you again for the invitation, and see you sure see you next year. Thank you very much.